Hello, my name is Dan Satnick, and today we will be discussing the development of a quality improvement tool for peer evaluation of documentation and clinical care in the emergency department. This is talk about documentation care and how we can do better. If we take away all the annoyances of documentation, the billers, the crashes, the sepsis alerts, the heart of documentation is to communicate a patient presentation, evaluation, and treatment. We need to synthesize everything that is happening into this note, and we need it to make sense. When my colleagues read my chart, I want them to look like the woman on the left, not the man on the right. Now, you may be asking yourself, why are we talking about this? I did residency, I've been practicing independently for a while. Well, then you may also realize that documentation is not strictly a focus during or after training. The percent of cases with charting errors in emergency medicine is unknown and likely a function of how it is defined, but one single center study found that charting errors by trainees in a teaching hospital to be 14% after an intervention was conducted. While emergency medicine residents feel they require more training in documentation, this is not well studied in attendings. In addition, most departmental training for emergency medicine attendings usually focuses on billing rather than medical, legal, and clinical charting. It's probably because it's hard to make a direct connection between money and better documentation, but it does exist. Poor documentation, discrepancies between attending, resident, PA, and nursing notes, missing medical decision making, and missing progress notes, as well as inappropriate care, play a major role in claims and payouts of emergency department medical malpractice cases. So even though we may feel like this person when we try to sit down to write a note on shift, the lawyers won't have any of those distractions when looking through your chart. Okay, all this is background, you know this, so how do we get better? Like most other skills, it starts with evaluation. Here's another number, 4. That's how many charts each attending at our site had reviewed on an annual basis. 2 charts bi-yearly as part of an ongoing professional assessment by our department chair, Dr. Eric Lagom. One person and 4 charts is hardly enough for significant feedback. We realized that a strategy to regularly alert our attendings of suboptimal documentation and patient care was needed to improve care and avoid costly errors in the future. In discussion with other department chairs, Dr. Lagom discovered there was already a tool created for a similar purpose. The slide above highlights a scoring tool used by Klasko et al. To assess the rates of error and adverse events in the emergency department. As you can see, there's 7 categories, and they use the Likert scale 1 through 8 to rate the charts in each of the categories. We modified this previously developed template that demonstrated high inter-rater reliability for more streamlined, simpler, and generalized applicability. For our scoring tool, we chose to focus on documentation and clinical care. Our thought process was they were most easily determined from chart review, and they incorporate aspects of the other criteria listed above. Here you can see the scoring tools that we developed. 1 being the best, 5 being the worst on a 1 to 5 Likert scale. You can see documentation on the left and clinical care on the right. We're going to take a closer look at scores 1, 3, and 5 for each of the scoring sheets. Here's 1. You can see that for a score of 1 for documentation, charting is complete for all major elements, and the scorers have an opportunity to select options they feel are appropriate. For 3, you can see the chart is inadequate for the complaint, and there's some options listed below. And for 5, you can see this is a marked deviation from standard or minimal expected documentation. For clinical care, you could see we deemed a 1 fully appropriate for the presenting complaint. For a 3, we determined that most attendings would have managed the case differently. And for a 5, it was indefensible for a poor outcome. We also provided the reviewers with example cases that would fit each of those categories. So we had 8 experienced attendings evaluate the same 10 charts using our scoring rubrics. These charts were specifically selected by Dr. Lagom to provide a mix of what he considered excellent, adequate, and poor documentation in clinical care. They scrutinized those charts using our tools, and then we checked the consistency among the raters. The Shrout-Felice relative fixed set mean kappa scores are listed above, and you can see we determined that we had excellent consistency among raters for both documentation and clinical care. In all, we concluded that this scoring tool would be reliable for use among our attending physicians. We then expanded the tool to include all our attending providers, a group of 58 attendings, and assigned 12 charts to each attending for review. There were over 600 charts reviewed in our practice. We provided the blinded, consolidated, individualized feedback to each attending at the end, and you can see some themes emerge for inadequate documentation: lack of evaluation or notation of competency on AMA, inconsistency between resident and attending charting, and lack of reassessment. Overall, we believe that by requiring all attending staff to review a specified number of charts using a template with explicit criteria, they'll have a better understanding of the elements of a good chart as well as opportunities for improved care and resource utilization. The process can easily be generalizable and scalable to any emergency department looking for a comprehensive review process for documentation and clinical care. Thank you.